Hey everyone, look, you've been asking us to make high-yield ATI videos to pass your ATI quiz, and well, you are in the exact right place. Let's dive straight into this explainer on Chapter 18, The Preschool Child. We've gone ahead and distilled all that heavy textbook reading into the absolute high-yield blueprint you need, so grab your notes because we are getting right to the point.
Think about it this way. Everything that happens between the ages of 3 to 5 serves one massive foundational goal. As the source material states, the major task of the preschool child is preparation to enter school. That means developing cooperative play, controlling bodily functions, and this is absolutely crucial for your nursing assessments, accepting separation from their parents. Basically, every milestone we cover today bridges that gap from a highly dependent toddler to a totally school-ready child.
To get you completely test-ready, here is our agenda. 1. High-yield preschool development. 2. Magical thinking and language. 3. Play is serious business. 4. Discipline and daily care. 5. Safety and accident prevention. And 6. Enuresis and clinical care.
All right, starting us off with Section 1, High-Yield Preschool Development. You literally need to write these specific numbers down because this right here is pure exam gold. Just look at how rapidly a preschooler's brain develops year over year. At age 3, their vocabulary is sitting at about 300 to 800 words with a 15-minute attention span. By age 4, boom, vocabulary explodes to 1,500 words and attention hits 20 minutes. And by age 5, we're talking a whopping 2,000 words and a solid 30-minute attention span. Understanding this trajectory is exactly how you quickly identify if a pediatric patient is facing any developmental delays. Oh, and here is a standalone magic number you just have to memorize: 20. By 4 years of age, all 20 primary teeth have erupted. Trust me, this is a classic multiple-choice distractor fact. So when you see a question asking about expected physical findings in a 4-year-old, looking for all 20 primary teeth is a very safe, evidence-based bet.
Moving right along to Section 2, Magical Thinking and Language.
So, to really understand how preschoolers communicate and why they might be absolutely terrified of your standard medical equipment, we have to look at Piaget's pre-operational phase. Piaget breaks this down into 2 heavily tested stages. First, you've got the preconceptual stage. That's from 2 to 4 years old, where symbolic functioning rules. Basically, an empty cardboard box is suddenly a fortress. Then comes the intuitive thought stage from 4 to 7 years. Here, thinking is pre-logical and based entirely on outside appearances. This shift brilliantly illustrates how a child's reasoning matures, moving from pure imagination to actually trying to make sense of the physical rules of the world around them. Because of that pre-logical thinking, kids do some pretty fascinating things. First up is animism, which is the tendency to attribute life to inanimate objects. If a preschooler trips on a chair, they might actually think the chair is mean. Or they might think a fallen autumn leaf is hurt because they actively apply human feelings to non-living things. When you're about to use a blood pressure cuff, keep this in mind. To them, it might be a living, breathing thing that squeezes their arm.
Next, we have artificialism. This is the idea that people created the world and everything in it. For example, a child might think someone physically painted the sky blue or turned on a giant switch to make it rain. Quickly lock in this definition to help you differentiate it from animism, because nursing exams absolutely love to mix these two up in matching questions.
Then there's centering. The crucial point here is that a child might think a tall, narrow glass holds way more juice than a wide, short one, simply because it's taller. They concentrate on a single outstanding characteristic, the height, and entirely exclude the width. They just don't have the logic yet to understand volume.
Now, regarding language development, a quick red flag we must talk about is echolalia. That's the repetition of words without comprehension. While it's somewhat normal for a younger toddler to just echo what you say, if a 4-year-old is exhibiting echolalia, well, that's a red flag. The text specifically notes that this requires a referral for follow-up care. Keep that tucked away for your assessment questions.
Section 3, Play is Serious Business.
In the pediatric world, play isn't just goofing around, it's how they learn, cope, and develop. So let's track how play evolves year by year. At 3 years old, play is mostly parallel or associative. They might play next to each other in a sandbox, but they aren't deeply collaborating. By 4 years old, we see highly imaginative and rough-and-tumble play. They're really testing their physical limits. Then, by 5 years old, they want to play games governed by actual rules. Though a fair warning, they might get incredibly frustrated if they lose.
This is where we come in. As nurses, we actually use play for healing. This is called therapeutic play. It aids in retraining muscles, improving coordination, or helping a child process the severe stress of being hospitalized. A classic ATI example is having a child blow out a flashlight as if it were a birthday candle. Why do we do this? Because it playfully forces them to practice deep breathing and lung expansion without making it feel like a painful, scary medical task. It's honestly brilliant.
Okay, on to Section 4, Discipline and Daily Care.
Parents are going to ask you for guidance on behavioral issues constantly, so you need to know the evidence-based responses. When it comes to timeouts, timing is absolutely everything. It must be administered at the exact time the incident occurs to be effective. You just can't tell a preschooler, wait until we get home. Their memory and concept of time won't connect the punishment to the action later. Furthermore, the text makes it crystal clear spanking is not effective, and it inappropriately models aggression to the child.
So what about thumb sucking? Parents panic over this all the time, but you need to reassure them. It's instinctual and it is completely normal. Most importantly, it causes absolutely no harm to the teeth as long as the habit is discontinued before the permanent teeth erupt. Also, let me just act as your study buddy here for a second. Regression is entirely expected during periods of stress, like hospitalization. A potty-trained 4-year-old might start wetting the bed or sucking their thumb again. Do not let a test question trick you into labeling this as an abnormal developmental delay. It's just a normal stress response.
Next up, Section 5, Safety and Accident Prevention. Here's the thing. A preschooler's physical independence vastly outpaces their judgment, which makes them highly vulnerable. The major threats you need to counsel parents on include falls, automobile accidents, burns, and poisoning. Because they have improved motor skills now, they can climb up to grab matches or pull a hot cup of coffee down onto themselves. And poisoning is a massive risk right now because of that magical thinking we talked about and their intense desire to imitate adults. If they see mom or dad taking a bright, candy-colored pill, they're going to want to take one too.
And definitely don't forget water safety. Unsupervised water play can quickly lead to unexpected, tragic injuries. Their immature judgment makes indirect supervision an absolute necessity at all times. Drownings and falls are major, preventable threats, and parent education is your primary nursing intervention here.
All right, our final stretch, Section 6, Enuresis and Clinical Care.
Enuresis basically just means involuntary urination, bedwetting, after the age when bladder control should already be established. For exams, you must be able to differentiate the two types. Primary enuresis refers to bedwetting in a child who has literally never been dry. Secondary enuresis, on the other hand, is a recurrence of bedwetting in a child who has been completely dry for a period of 1 year or more. Differentiating these is step 1 in proper nursing assessment because secondary enuresis might point to a new acute stressor or even an infection.
So how do we treat it? Well, the golden rule is always to rule out organic causes first. Things like urinary tract infections or diabetes before just assuming it's behavioral. If it's not organic, your first-line defenses are behavioral. Limit liquids after dinner and have them void right before bed. Now, if medications are required, you might see desmopressin, which reduces urine production overnight. You might also see imiprimin. That's an antidepressant that reduces urinesis, but beware. It has significant side effects like mood disturbances and GI upset, and an overdose can actually be life-threatening, so always monitor closely.
Let's wrap this explainer up and put you to the test with an actual NCLEX review question. Ready? An example of a therapeutic play activity for a preschool child recovering from an appendectomy would be 1. Wee bowling, 2. Blowing bubbles, 3. Reading a story, or 4. Coloring. Think about it for a second. After abdominal surgery, we desperately need to prevent pneumonia by expanding the lungs. Therefore, the answer is 2, blowing bubbles. It perfectly masks a medical necessity inside an age-appropriate fun game. So as you head into your exam and eventually your actual career, I want you to ask yourself, what other terrifying medical procedures could you completely transform just by speaking the magical language of play? Keep thinking about that, and I promise you, you'll do more than just ace your ATI quiz. You are going to change your patients' lives.